Good afternoon, everyone. Thank you for being here. Thank you for filling up on pizza. Welcome. It's Wednesday, it's noon. Here we are with our IPEC event. This event is a collaboration between IPEC and ESPERT. So IPEC is Interprofessional Education Collaborative. It's a group of faculty who work together to bring you extracurricular interprofessional opportunities during this Wednesday noontime hour. We're calling this a shared learning opportunity. If you were here last week, it'll run basically the same way. We have a fantastic panel who are going to tell you a little bit about the landscape for helping people with substance use disorders here in Southern Maine. And then it will be open to questions. And so I hope that while they're talking, you are asking yourself questions about how can I interface with these folks? How can this help me take care of my patients? How can knowing they're out there make me more confident and secure as a practitioner? Just have a few announcements before we get started. Because this is co-sponsored by ESPERT, does anybody know what ESPERT is? Oh, the marketing is making its way out into the world. That's nice. So ESPERT is screening, brief intervention, and referral for treatment for substance use disorders. It's a system more than it is a thing. So all of you, regardless of your health profession, screen for various things. That's the S. All of you have conversations with your patients, and your patients are there because there's something they want to change. They want to feel healthier. And so you have conversations with them about how they can be healthier. What is their motivation to do so? I've certainly been motivationally interviewed by my dental hygienist enough to know that I should be flossing, and it's good for me. So she has motivated me. Referral to treatment, you're all referring for different kinds of things. So that's just ESPERT in a nutshell. What we're doing is applying those tools to substance use disorder. So there are some ESPERT student leaders in the audience. Can I ask you to stand or otherwise identify yourselves? Got some here, thank you. Excellent. So if you have questions about the student leader program, ask these ladies. Also blocking the exit up here is a sign-up sheet if you want to sign up to be an ESPERT student leader, and there's more information there as well. So what is happening today, which is very unusual, is we're having another event that's exactly like this with a different panel in Biddeford at the same time. And most of this has been organized by Brianna Nally, our program assistant for ESPERT, so I just wanted to shout out to her. We do have some upcoming events. On Thursday in Biddeford, we'll be doing a MI, motivational interviewing training for people who are interested in ESPERT student leadership, and I would love to have you join us, and you can sign up on your way out. And our next IPEC event is Wednesday, October 4th, and we'll be talking about cancer care, interprofessional cancer care. As you know, if you've been to these events, there's an attendance card. Some PTs have signed them and given them to me already because some folks have to leave at 1. So panel, don't take it personally if folks have to leave at 1. And if you do have to leave at 1, just go quietly. Thank you. But make sure we get your attendance sheet. We're coming up on a time where this will be the attendance of record, and we'll be reporting back to your programs who's attending. So take it serious. Don't fill it out for your friend who's not here, if you can possibly help it. And the other incentive for filling out the attendance card is you get put in a drawing for a $10 gift card to the bookstore, and today's lucky winner is Sadie DePero. Sadie. This must mean there's a lot of pharmacists in here. Yay. Are you Sadie? Thanks for coming. You're a winner. All right, so the last thing I want to do is just get a sense of who's in the room. So pharmacy, we have heard loud and proud. Thank you for being here. And social work, I get a sense. Woo, social work. I learned from last time I forgot to list social work, and the trouble I got in. Any nurses? Oh, I see some nurses. Dental hygienists? Yes. Let's see, PAs? Got some PAs. All right, who? PT, yes. OT. OT. Okay. Anybody else? Dental medicine? Awesome. Thanks for coming. So that's the end of my speech. I would like to invite our panelists to come on up on the stage. We're going to do probably 30 minutes of hearing from them, their various areas of expertise, and then we're going to open it up for questions. So be thinking about what are your questions for this amazing resource we have here in front of us today. So we have Darren Ripley, and we have a recent graduate from the social work program, Daniel Bell, and we have Oliver Bradeen from the police department, the Portland Police Department. Are you an officer? I'm not. You're not an officer. All right. Yeah. And then we have Bridget Rocher, and then we have Zoe Odlin-Platts, and we have Sarah Faruja. So I would like to just set you up with the question is if you could just tell us who you are, what you do, if you have a title, that, and what, and Darren is telling me to start with Sarah, so I'll do that.
You gave me the hard one.
I know, I'm sorry. And what organizations you work for, and a little bit about your story. How do you work with folks with substance use disorders, and how can the health professions interface with you? Thank you.
So I'm Sarah Faruja. Can everybody hear me all right? Okay. I am in recovery from opiate use disorder, first and foremost. I am a mom of 2 kids. I have an almost 3-year-old boy and a 9-month-old girl. I grew up in Ann Arbor, Michigan, and I moved to Maine about 3 years ago. Here in Maine, I like to do a lot of advocacy work around substance use disorder and have been working with Young People in Recovery, YPR, to really spread the message of lowering stigma and changing our language and just changing our views on substance use disorder. I think I'll pass with that over to Zoe.
So I'm Zoe Odlin-Platts. I work for the City of Portland's Public Health Division, and my primary focus there is running the needle exchange program. So I work with people who are actively using, and our focus and our sort of primary goal is to educate and offer safety and a supportive and trusting place for people to be so that they can have one place in their life that they feel comfortable talking about their drug use without being judged, and really kind of exploring ways to help empower them to be as healthy and as safe as they can be in that moment, and build that relationship so that if there's other things they want to explore later on, like access to primary care or treatment for substance use, we've built that foundation of trust, and they will come and really have an honest conversation about what their needs are. And for a lot of the people we see, we are sometimes the only place that they access any sort of medical care, and we kind of are able to offer a variety of services ranging from HIV and hepatitis C testing and education. We have the state's last remaining STD clinic on site, so we do a lot of STD testing and referrals to our clinic there. We have a new partnership with Maine Med, so we're really working on building that collaboration around making sure people who are uninsured have access to Maine Med's free care program. About 85% of the people we see are uninsured, so that's a lot of people who really are not accessing much in terms of medical care. And then a big piece of the work that we do is making sure everybody has access to Narcan and doing overdose prevention trainings with every single person who comes into our program. And so with that comes the data collection piece of making sure we're getting reports on the overdoses that people are reversing. And we've really, since January, we've really beefed up our data collection. So in the first 6 months of 2017, we already had over 150 reported reversals from our clients reversing overdoses in the community. So data is a big part of what we do so that we can share that information and help educate our clients, but also our broader community about the philosophy of harm reduction.
I'm Bridget Rauscher. I also work for the City of Portland's Public Health Division, where I am the Substance Use Prevention Program Coordinator. And that role sort of involves a couple of things. I oversee the Overdose Prevention Project, which essentially provides education and outreach and advocacy to the community, to people who are actively using, but also friends and loved ones and community partners and other providers. And work collaboratively with both of the folks on either side of me. And I also receive funding from UNE's Prevention Services grant, so I also do a lot of primary prevention to prevent the early use or misuse of any substances, so working a lot with families and schools, and again, community partners to sort of troubleshoot the best ways to delay sort of early use for young people. We do utilize the SBIRT model in a couple of the projects that we work on, which we can talk about probably later, but that's sort of the majority of the work that I do.
I got this one. All right. I'm Oliver Berdine. I'm the Substance Use Disorder Liaison for the Portland Police Department. I'm not a police officer. I'm a master's level clinician, but I respond in the city of Portland when an opiate overdose happens with fire, with MedQ, and with the Portland Police Department, and help everybody through that process, from the person that's overdosing to the family member, to the people in the community, to the first responders, and try to sort of de-escalate and make sure that process goes as smoothly as possible. The other thing that happens is in the state of Maine, you're not required to go to the hospital after an overdose. The naloxone or Narcan will wear off 30 to 90 minutes later. That person could go back into overdose. So we really want people to go to the hospital. A lot of times people are reluctant to do that, or they don't want to be there by themselves. So I often will go with them to the hospital, sit through the process with them, make sure they're getting quality care at the hospitals, make sure that they're getting phones if they need to call a loved one, all those kind of small things that kind of get lost at times. Or they don't know that they can ask for. Help the person through that process, and then unfortunately a lot of people don't have referrals directly from the hospital back to some sort of treatment. So I then can follow that person back out the door if there's no immediate referrals, and stay with them if they want and work on finding treatment. And sometimes they're not ready for treatment, so I can still follow them if they want, and we work on harm reduction practices, usually connect them to the needle exchange if they're not already, and just follow them as a low barrier person. There's little to no documentation for my job, and they don't need insurance, so I'm a very low barrier. The biggest thing that scares people is my connection to law enforcement. That is only there so that I can know when overdoses happen. In addition to that, I do a lot of street level outreach when there aren't overdoses actively going on, checking in with people, following up, trying to help get their basic needs met. Yeah.
Hi everybody, my name is Danny Bell. And I'm like Chris had mentioned, I'm a recent graduate of the University of New England social work program. I graduated in December 2016. And yeah, I'm also a person in long-term recovery. I've been sober since 2012, October. And you may have seen me in the gym from time to time if you guys are current students here. But I've served in a number of different positions. I think one of the kind of driving forces for me personally to get into this work was the fact that I have lived experience, and so it kind of gave me like a pretty strong passion, you know, to be able to help somebody, and also it's been a driving force in the work. Like I said, currently, so I'm a licensed clinical social worker. I'm also a certified alcohol and drug counselor in the state of Maine, and right now I'm working at a 30-day residential program in rural New Hampshire. So I'm a direct service provider, so I provide clinical counseling to people with substance use disorder. And prior to that, I was working at a small outpatient therapy clinic in Saco, and what I want to say, I guess there's kind of like a popular misconception that mental health and substance use are kind of two separate entities, and what I've come to realize that they're so like interrelated that it's really important. And in terms of my own practice, so in the beginning of this work, I got sober through 12-step recovery, so I kind of integrated a lot of those principles into my work, and when I went to UNE and got a higher level of professional training, there were certain things that I felt really drawn to, and one of those was motivational interviewing, and even so I understood like the basic theory of it, it was something that kind of really, it resonated with my own values, and I think earlier in the summer I took a motivational interviewing training in Portland with this guy Stephen Andrews, and it really changed my practice. I feel like it's a way to have a conversation with people that's not threatening, it's not intrusive, it's a collaborative approach, and so I utilize a lot of that stuff in my work with people where I work currently, mainly because I feel like there's a lot of ambivalence with people, who want to make change, and that goes for anything, exercise, any kind of healthy choice. And also, too, it's a way to kind of get people to talk about themselves, and I think there's also like a lot of stigma around substance use, and like I've kind of struggled with that on a personal level of like how much do I disclose about my own story, and so I think a lot of people who make contact with a PCP or a dentist kind of come into that with that kind of shame, and that stigma, and I think using motivational interviewing is a way to kind of get people to disclose things about themselves in a way that they feel comfortable, and so I'd really advocate for any provider in the helping professions to kind of take one of these trainings. I was at this training in June, and there was a number of people in there. It wasn't all clinical social workers. It wasn't psychologists. There was actually some people who were like trainers at a gym that were taking it, and so I'll just leave it with that. I'm going to turn it over to Darren. Thanks for being here.
Hi, everyone. I'm Darren Ripley, and I am the Executive Director for the Maine Alliance for Addiction Recovery. I'm also a licensed alcohol and drug counselor and a certified clinical supervisor. I think most importantly, though, given all of those acronyms and what I am a person in long-term recovery. And what that means for me is I have not had a drink or an illicit drug since June 30th of 1992. And I am also a person in long-term recovery from a mental illness. So, I guess I get, you got some PT people in here and everything. So I think I can get some help before I leave. All the way around from some folks. And I'm going to refer to it as MAR from here on out at the Maine Alliance for Addiction Recovery. I provided direct service for many years. I also worked at the Office of Substance Abuse when it was called OSA. So I am, I guess, aging myself a little bit for those of you who have never heard of OSA. I know it is SAMS now, but since 2012 I came over on the recovery side and started as a coordinator at the Maine Alliance for Addiction Recovery, and now I am the executive director of that organization. And what we are is we're a recovery community organization, and a lot of what we do is we educate and advocate on behalf of people who are in recovery from a substance use disorder. We also support the many pathways of recovery that exist within our state and work to establish comprehensive recovery communities as we are doing that. And the Maine Alliance for Addiction Recovery establishes peer recovery support programs for individuals and family members. So we train community members to serve as peer leaders and mentors One of the many trainings that we've had, that I have had, has been recovery coach trainings. I've done 23 of them in the state. And I saw someone walking around here earlier with their hand. Hey, I saw 2 people walking around that went to the training last year. Nice to see you. So that is a little bit of what we do. We do lots more than that, but I'm not going to rattle on. Thank you.
You could hand your microphone over to our 7th panelist. Deborah will take a moment to introduce yourself, what you do, and how you interact with people with substance use disorders. Thank you.
Good afternoon. My name is Deborah Ouimet. I'm a clinical counselor in substance abuse for groups in Portland, Maine, which is a buprenorphine clinic, and I also have a private practice. I've practiced in both New York and in Maine. And I'm thankful for being here and apologize for being late.
Okay, so wide variety of resources and approaches, and what I'd like to do now is open it up. If you have questions for them, I think that they're happy to field anything you might want to know, and if we can't answer it, we'll find out the answer and get it to you later. So does anybody have any questions they're burning to ask? Everything's very clear? Are you way over there? All right, here's my steps for the day.
So good afternoon, I'm Daniel. And my question is, well, change is one of the most difficult things that anyone can do, whether it's developing better study habits or discontinuing toxic habits. But how does one, as medical providers here, how does one, I guess, or promote change for someone that isn't ready to change, for like patients?
I'll start with that. Is this on?
It's a question from a dental medicine student.
So I think the first thing that comes to mind to me is that you can't. You're never, I mean, it was actually Steve and Andrew who told me this a couple years ago, that, you know, unsolicited advice is like your mother when you're 13 telling you to do something, and you're pretty much guaranteed not to do it, or at least that was me. And it's kind of the same thing, like when we tell people or we say, you know, you should do this, like you should stop injecting drugs because, you know, you keep going to the hospital and you have these reoccurring abscesses, and why would you keep doing this? You've already lost the person, gone at that point. And I think the same goes for a variety of other things. So I think that's how the way we try to approach change is providing information and sort of allowing the person to feel motivated by the information, and like you might not see the change right away for a while. One of the highlights of my work is whenever I encourage somebody to use alcohol pads prior to injection, and they're completely resistant and they're not going to do it, and you know, they can't understand why they keep getting these infections, but they're absolutely not going to clean their skin prior to injection. All right, fair enough. I'm going to keep putting those alcohol pads in that bag every single time you come in and just remind you that it's a good idea. And with everybody, almost at some point, I've had every single person comment on what a difference it has made in the way that they feel and the health of their body, and sort of how their rate of infection has decreased. And same goes for using alcohol pads after injection. People can't understand why they're seeing all of this bruising. They've got all this excessive bruising on their arms, and encouraging something as simple as a gauze pad versus an alcohol pad will make a world of change. And then you've got them. Like at that point, I think once you sort of create that environment that is comfortable. You're not telling anyone what to do, but you're just sort of providing this information. People will feel empowered to make their own decision just based on the education. And so that's sort of my first thought to your question.
I just want to, to piggyback on that a little bit. And, I know there's so many medical students in here, and, looking at it now, I see that, a lot of the medical folks are front line that you're seeing, and it's getting tougher. And, going back to what Dan had said, you really can't, if somebody, you see the problem, you know they really need to change. They're not ready for that, and granted, you're not going to just snap your fingers. I mean, every 6 months when I go to the doctor, my physician, they ask me again how am I doing with my smoking, and I put my head down. Cigarette smoking. I want to make that clear. And I put my head down, and they offer it. Whatever help, he just kind of leaves it at that, because if he starts squawking about it, my ass is up and out of there. That's the way it is. Being, hitting on the motivational interview, and I think that's very important. I've been doing motivational interviewing for 20 years. I'm a trainer in motivational interviewing. I think, maybe having some of those skills a little bit so they don't feel that they're trapped in a way, and just know that they're listened to, that they know they can come back to you if they need that help. I think leaving that door open is one of the biggest things, that we can do. They may not want to help right that day. However, if they know that there's somebody there that cares about them, that is going to listen to them, that can help guide them through that, hopefully they may come back.
I think that was a very excellent question. And my kind of take on that is I agree with Zoe. There's definitely providing education. And also like letting people know that there's resources there and there's options. Because I feel like when people feel like they have a choice and they have options, they're more likely to change rather than kind of like exerting your will on somebody. And I feel like most of the time, when someone's engaged in a behavior, there's some part of them that doesn't sit well with them. And we want to kind of like bring that to the surface and kind of, we want to like kind of weigh the pros and cons, of making a decision. And I feel like it's really important to build relationships and ask those questions. I feel like a lot of people aren't comfortable asking those questions. And so there's a perception by the client or the patient that, this provider isn't really interested in this. And so I think like kind of planting those seeds, providing information, providing education, letting the person know that there is resources, there are options, can go a long way. And like people had said, that may not result in a significant change right away, but further along the line, that stuff gets kind of lodged in the back of their psyche. And then when they're ready, they're ready. So.
I feel like there's another question embedded in the question that you asked, which can highlight the difference between a zero tolerance approach to recovery and a harm reduction approach to recovery. And I wondered if one of you could sort of speak to those two approaches and just let us know what the difference is. Because if they're ready to change doesn't have to mean cold turkey tomorrow. Change can mean one less drink or one, so.
Back in the day, it was all abstinence-based treatment. Over the course of time, with SBIRT and with more use of motivational interviewing, clinicians and medical providers are helping clients elicit change within themselves. Harm reduction is exactly what it says. It's to reduce the harm of the drug or the substance being used. So when you're working with someone, it's to give them those choices, give them those options, know what the normative levels for drinking are, know what the normative levels for use are, know what harm is to the body that's being done to the body and brain, and then use your motivational interviewing techniques to help them move through the stages of change. So they can move from pre-contemplation to preparation to action, and then take steps to change within themselves. A lot of times in addiction treatment today, we use the harm reduction approach. It seems to work better, and a lot of providers are talking to their clients and talking to their patients about the harm that is being done as a result of use. And they can find out what their knowledge of drinking levels or use levels are. So harm reduction is being more widely used today as a treatment model.
I'll just touch on this a little bit. So when I first entered recovery, I was 17 years old, and I entered an abstinent-based program and was in and out of that for several years. Today, I practice harm reduction, and what that looks like for me is, I might go home and have a glass of wine at night. I don't practice an abstinent-based recovery, and I think what's really important to understand is substance use disorder is not a black and white, disorder, and so our treatment, our referrals can't be black and white either. We really need to see what the gray area is, and for me, that gray area has been harm reduction. An example close to my heart is I have a family member who was actively using heroin, and he went through this really beautiful course of harm reduction. So started off with injecting heroin. Later, he was injecting Suboxone that he got illegally. After that, he was injecting Suboxone from a prescription. He got his own doctor and was doing counseling with that doctor. And then he stopped injecting it, and there was no more needles, and he was taking his Suboxone. And then he was taking his Suboxone exactly as prescribed. And I know that may seem really small, but those changes have led to this person, being a productive member of society. So I want to echo that meeting someone where they're at, even if it is still using, and making sure that their use is as safe as possible is really the best approach in my eyes.
And just to note that medication-assisted treatment is seen as the best evidence-based practice for opiate addiction. So the medication-assisted treatment could be in the form of Suboxone, and it could be in the form of methadone as well for patients with opiate addiction. And they get their lives back. And part of getting their lives back is learning that the harmful effects of using have caused problems in their lives, but they learn this through using medication-assisted treatment to help them with growing in their family, in their community, getting employment, getting housing, and it works very well.
Any other questions? Question? Oh, we've got some down here.
Thanks. Hi, Lila Maycock. I'm in the social work program. So this is a question, I'm mainly pointing this at Oliver. So if there's someone who calls in and says, hey, my friend's having an overdose right now, and I happen to be holding some type of drug on my body. So what happens in that situation? Because I know that there's a Good Samaritan law for if you use Narcan on someone, but if you actually have drugs, then will you be arrested? And how do we address this? And if that happens, how often do you see folks get arrested from that in your position?
That's a good question. So it depends on where you are. There's no Good Samaritan law for overdose. There is a medical Good Samaritan law. So if you administer, Narcan or CPR, you'll be protected if that person still dies. But if you call 911 and they respond, then it is up to the discretion of that department. So at our police department in Portland, the chief has told them that at most you will be issued a summons for possession. That happens very rarely, at least when I'm on scene. I can only speak to when I'm there. For the most part, they're not searching people. If they're testing drugs, it's usually to make sure they know what it is. Sometimes I've actually requested that they test stuff just to know if we're dealing with heroin or something else. But that's not used in any criminal way. That's just to make sure we know what's going on. So the unfortunate answer is there's no hard and fast rule. It's a gray area. It's up to discretion. I still encourage everyone to call 911 just because there's such a complicated medical issue going on. Sometimes there's more than just opiates on board. Sometimes there's a medical emergency on top of the opiate overdose. You know, if people, we always talk about in overdose trainings, if you're afraid of yourself getting in trouble, call 911. You know, make sure the person is in a place where they can access them. But then, you know, if you're going to leave, but make sure the person is as safe as possible. Part of my job is to keep people out of jail, so I, at all times, am telling the police not to arrest anybody. They will arrest people for warrants at times, so a Good Samaritan law would protect people if they have an active warrant, or the ones that they've tried to pass in the state of Maine would protect people if they have an active warrant so that that person will be willing to call. I review all the overdoses in Portland, and majority of the fatal ones, people either wait to call 911, they don't have Narcan, or they left the person alone for an extended period of time. So a lot of times people panic because they want to help their friend, but they're afraid of everyone getting in trouble, or they're using themselves and they're worried about getting in trouble, or they're on probation. So they wait to call for 20 minutes, and at that point it's too late. So, you know, people can get rid of what's on them if they want to. For the most part, they're not getting searched, though, in my experience. I don't know if you're hearing other things from people at the exchange.
No, I would say, right, I would say when people are calling 911, at least in Portland, we're pretty fortunate that we have a police department that is aware of the appropriate way to deal with these calls, right? But what we're seeing in the exchange, which sort of echoes like this broader issue of not having a Good Samaritan law here in the state, is that only about 30% of the people that we see are calling 911. So when somebody comes back and tells us about a reversal that they were involved in and that they used their Narcan, we always ask, what else did you do? You know, did you do sternum rub? Did you do rescue breathing? Did you call 911? Did you do compressions? You know, what felt right to you and what did you do? And only about 30% of the people are saying that they called 911. Now, we see people from all over the state, so it's really hard to know where they're, you know, we also ask where the overdose occurred, but there's so much sort of systemic issues around people who are actively using and law enforcement that even though we have a police department and people have really good experiences here in Portland, those calls, most of the time what I hear is, you know, I gave Narcan, I used all the Narcan that I had and the person still hadn't responded, so then I called 911. And at that point, that really is waiting too long, but I'm also not going to tell somebody, you know, who's grieving or who's totally freaked out by interactions with law enforcement because they do have warrants or they're on probation or there's children in the home or, you know, these varieties of reasons why people don't call. You know, that's what can get in the way of it so much.
And I'll just add, I feel like the kind of philosophies are kind of changing with a lot of systems, like, thank God. I know when I was a student here, I went up to the state legislature. We were advocating for legislation that instead of like arresting people and prosecuting people, we were kind of divert them into a treatment. And there was a lot of police chiefs that were present there, and their kind of view was like, we can't like arrest ourselves like out of the, we can't arrest this problem, like we can't just like incarcerate people. And so I think slowly, like, there's been more awareness and more education in what's effective, because I think in the past we put substance use disorder as solely like a moral issue, you know, and we need to treat it with punishment and in incarceration. And I see that slowly shifting in places like Westbrook and Portland. So I feel like that's more effective. And in my own personal experience is, you know, had an opportunity to enter treatment as opposed to being incarcerated and thank God that was the case, because I don't think there's no treatment, in jail, in prison. And so I think, what Oliver's doing with the Portland Police and their willingness to kind of form those relationships is really signifies like kind of a shift in the larger systems. And I think that's all for the good, and just kind of people be willing to speak on panels like this and bring some awareness, and be like, yeah, I struggle with this, and because I had resources, I have a pretty good life now, and I can help other people. So.
Another question? Was that a hand?
Hi, I'm Abby Maycock. I have a question about the degree of fentanyl that you guys are seeing, or if you're seeing any in this community in Portland and kind of the state at large.
At this point, I pretty much assume everything is fentanyl. I mean, I don't know. The majority of stuff I see at overdose calls is fentanyl, and sometimes mixed with a benzodiazepine. So, which, for those of you who don't know, Narcan does not work on benzos. So, the overdoses look very similar. They both can repress your respiratory system. So, that's another reason to call 911 for a lot of people, is the Narcan will not work no matter how much you give them on the benzos, and the person could still die from that. But yeah, every once in a while we have like actual heroin around, and people that I'm working with are kind of glad about that, just because it's a little safer and it's different. It works differently in the body, but most of the time it's fentanyl these days. Yeah, that's why I was saying we test the drug sometimes, just because I'm like, is this actually heroin? And most of the time it is not. So.
I think, what we don't have is really consistent testing, which would be nice, because we only get a snapshot. Most of the time, it's only what we get back from the medical examiner's office, so we're only getting really accurate results on fatal overdoses, which is why I rely on what our clients are telling us. And so, like, for example, on Thursday of last week, I think I had 5 people tell me that we were gonna see a big spike in overdose over the weekend, because somebody who wasn't around for a while is back around, and that's the person who was really in our area distributing most of what was believed to be fentanyl. The effects are very different. The half-life is much different. So most of our people know when they're injecting fentanyl or not at this point. It took us a while to get to that point. And then sure enough, on Friday, we had 7 reports by Friday afternoon. So, we rely really on the relationships we're building with our clients. Oliver and I interact with a lot of the same people. So we are always getting that information, sharing that information with our outreach teams, and making sure that people know, because a fentanyl overdose is significantly different than a heroin overdose. And when we go from having not a lot of fentanyl on the streets to having an abundance of it, we're going to see those overdoses spike, and we're going to need a lot more Narcan to reverse those overdoses. So there isn't a great answer, except that what we believe from what the people that we work with is that, yes, it's, we are seeing a lot of fentanyl, but we don't have a number.
So you've talked a little bit and touched on the idea of using motivational interviewing, and I'm wondering if you could, for those of the folks in the audience who don't know what motivational interviewing is, I'm wondering if you could speak a little bit more about what it is, what the technique is, and maybe even give an example of what that might, what it might look like.
Pop quiz.
You want me to try this? All right, I'll give that a shot. So my understanding of motivational interviewing is as a directive approach. So there's usually somewhat of a goal in mind. So that whether it's reducing use, stopping smoking, any kind of change. And essentially what I do, it's a way to kind of keep a conversation rolling. So what I usually do is I sit down with someone, it's a technique and really like being paying attention to what people are saying. So I do a lot of like reflection. So if someone says something to me, I'll kind of reflect that back to them. And in that, they feel like they're being heard. And also, what I try to do is, this term they have in motivational interviewing is amplifying ambivalence. So I kind of will weigh that, both sides of that out. So I say, on one hand, using provides you with the sense of ease and comfort. You feel like you're more social. But on the other hand, it also results in you being very isolated, and your family is really important to you, and you're not around your family. So it's a way for someone to kind of weigh the pros and cons of a behavior and make a decision for themselves. And although I have somewhat of an investment in them changing, they kind of make those decisions on their own, and it's a more empowering approach. So there's a number of different techniques in the MI, but I think that's basically like the underlying philosophy in it. And there's another saying, it's like, it's not what you say, it's how you say it. And I think like how you approach people, how you ask those questions holds a lot of weight, because someone can feel defensive or they can feel like they're heard, and that you understand them. And I've had a lot of people where I use motivational interviewing and I don't have to disclose that I'm in recovery, but they feel like they're being heard, and they're like, you must be in recovery because you know exactly where I'm coming from. So that's my description of MI. That's what I do.
It's a really great tool. It was one of the things that, I started out doing it, when following and became a groupie years ago of Stephen Andrews, and then was invited to a training of trainers. And I think the greatest part of my life, when you're changed in your life because you're role playing with Bill Miller and Stephen Rolnick, and I'm like, okay, it used to be a good Aerosmith concert was pretty cool, but that was really cool. And there was no way, even role playing, this guy had me. Bill Miller is just so great, and to be part of that. And when I came back with that, just having all of these tools, like Dan has said, when you're a clinician, it can be a long day. And if you're taking on what's happening with your client, in leaving with that, I didn't want to come in, not wanting to face work and then leave and be so stressed out. So, one of the things, it's their choice. Everything is their choice. And I think if you incorporate motivational interview, and no one is, probably except Bill Miller and Stephen Andrew, there are a few that will be 100% really great at it, but I just keep on doing it over the last 20 years, and we have resistant clients. I mean, one of the many things is I was given a lot of folks in direct service that were on parole, probation, through adult drug treatment court. They're resistant. They don't want to be there, and those are the people that I love to work with, because that was where I really got to hone my tools in on rolling with resistance. And amazingly enough, if just a lot of that you use, it means a lot to them. They feel they're being heard with motivational interviewing, and they feel they're being respected also. So as many of them that you can get to trainings, I would definitely say, and not just putting a plug in for Stephen Andrews, there are a lot of good trainers out there also, but you guys live in Portland and Steve's here, so he's good.
Thursday night in Biddeford, if you want to learn more. In the SBIRT system, motivational interviewing is characterized by a brief negotiated interview. That's the BI in SBIRT, and it's designed to be very quick. And I'm sorry that our College of Dental Medicine folks had to leave, but his question also brought to mind for me a primary concern for a clinician is, how long is this going to take? Right? I don't have time to engage in a 20-minute conversation every time I see someone. Our theory for the SBIRT grant is that because there are so many professions, everyone is screening or asking the question or engaging in the conversation just a little bit. And so if the client or patient is getting it from many different angles, then they know that somebody cares and somebody can have a neutral conversation with them that's not laden with the emotion that it might be if it was a family member or something. And the other thing I wanted to say is that as clinicians, you're seeing a population that takes, right, a bell curve for any number of things, whatever their condition is. And the same is true with substance use disorder. So 60% of your patient panel is not likely to be at risk. 20% is at a moderate risk, and they will benefit from this brief negotiated interview. The folks who are up here are mostly dealing with the top 10 to 15%, people who are in active addiction or seriously at risk for addiction. And so as a clinician, don't feel like every person is likely to be an addict, because that's statistically not true. And I hope that that relieves some anxiety about how you will cope with them, because you screen them out, then you have time to deal with the people who are at moderate or greater risk. Risk assessment is one thing that you're all doing in terms of some sort of screening. Can you talk a little bit about the screening tools that you use, or how you determine where someone is in a level of risk?
So for the people that we see, there's already that understanding that they are using injection drugs. So that is sometimes the hardest part for people, even, is just to make that step of coming into the needle exchange program, because it's like really having to admit where they're at with their own use. So that can be a really intense process, just like having somebody come into the room and say that they're here to sign up. We do everything as quickly, low barrier, and sort of effectively as possible, while keeping the person's anonymity sort of as top priority as they need it to be. For some people it's really, really important, other people not so much, but everybody remains anonymous in the program. And things that are sort of initially important for us to determine are things like housing status, what substances they are using, both by injection or other methods, their hepatitis C and HIV status, vitally important, and then their risk behaviors around their actual injection process. So are they sharing needles and equipment with anybody else? Are they, where on their body are they injecting, and why? We do a lot of safe injection education. So if somebody comes in and they're disclosing that they're injecting in their feet because they don't want anyone to know or see the marks on their arms, like, we brainstorm ways about how to not have as many marks on their arms if they're using clean equipment every time, and needles that have not been reused, and just those little simple techniques that don't always get passed down when somebody's first learning to use injection drugs, because most of the time it's somebody else who is also using, showing them how to use, and there's a lot of really good information out there, but then also sometimes there's information that's not as helpful or not as healthy as we would hope. And so we try to insert some of that education in the first time that they come in. We also talk about sexual risk behaviors. So we see a lot of people who are exchanging sex for whatever, a place to live, drugs, money, anything. And so really trying to get them in for STD testing while they're there, or have them come back if for some reason they're not ready to do it right then. And then based on what we get from that, we can really make some referrals into the community almost immediately. So for people who are Hep C positive, we talk about the program that we have, getting people treated for Hep C. That one's pretty easy, If they need to test, we try to offer them testing while they're there. If they've experienced a recent overdose, we talk about how that sort of further increases their risk for overdose in the future. We make sure they have Narcan, and most importantly, make sure that they are then going to go show somebody in their using circle how to use that Narcan, so that if they were to experience the overdose, somebody would know what to do. So for us, the risk assessment and the questions we ask when we first interact with somebody sets the foundation for sort of what they can expect. A lot of times people are like, oh, that wasn't that bad. I kind of like talking about my drug use, and you're not giving me any sort of weird look when I'm talking about it, so I feel safe and I feel comfortable, and that's exactly what we want. Every single person that gets trained in the needle exchange, we have a team of 16 volunteers now. The most important thing for people to remember to do is to make sure that we look everybody in the face and smile at them and tell them to have a nice day, because sometimes that could be the only time that that person gets that. So just setting that foundation with the questions that we ask and the information we provide, hopefully our goal is that that is creating the emphasis of like the safe space and the trusting environment and the compassionate education that we're hoping to provide.
So for Portland's substance use prevention program, we recently collaborated with the Portland Fire Department and the Oxford Street Shelter, which is Portland's emergency adult shelter. And that's a setting where we implement SBIRT, but not necessarily in a sort of standardized way. Essentially, what we've implemented is a community-based paramedicine project where paramedics from the fire department spend time each week at the shelter, and can sort of have folks who are staying at the shelter have open access to them, and they can come and ask about things that are going on medically, or talk, or just get some referrals, get condoms, get information about other services available in the city. But what's nice about it is that the medic, so if a medic is addressing like trench foot and maybe like soaking somebody's feet, they'll talk to every person about their substance use. And so it doesn't necessarily always look like the real typical SBIRT model. It's an opportunity to interact and with really low barrier, sort of similar to what Zoe was talking about at the exchange. Just sort of have that conversation without judgment and without imposing their own opinion, and really quickly determine if that person might be interested in talking about any sort of behavior change or treatment. And I think what's important to remember is that treatment isn't always, I think what's scary for providers is that they don't always have the resources, or they might not always know the resources that are available, and so they'd rather avoid the conversation instead of saying, oh, I don't really have, it's nice that you're ready to change or ready to do something different, but I don't really have anything to tell you. And I think that when we can kind of offer something, or offer the idea that just being able to support a person and have a safe place for them to talk about their use or talk about their substance use disorder is enough. So referrals to treatment might not look the way you want them to look or what you think they should look like, but sometimes just a referral to a harm reduction resource, or a referral to a primary care provider if a person hasn't seen one, or the reminder that they can access housing case management services is the beginning of a conversation. And I think that's as valuable, and a lot of times more valuable, than what you think treatment should look like for someone.
When SBIRT was rolled out by the Substance Abuse and Mental Health Foundation, what happened was they chose large hospitals. I was working in upstate New York in one of those hospitals, and what they did is they train doctors and clinicians to be able to use a simple screening instrument that is provided by SBIRT to talk with patients about their substance use, primarily alcohol use disorder when it was first instituted. Then they changed to substance use disorders the second year. So we were talking to them about both disorders as well as tobacco use. SBIRT was then, the statistics were taken back to SAMHSA. They came up with a screening tool which today is available in an app that physicians and medical professionals can use. As an SBIRT trainer, I trained the police department in New York State as well as medical professionals in using the SBIRT model. As a substance abuse professional today, I use the SBIRT model in with the psychosocials that I use. I also use what's called a DAS, drug and alcohol screening tool, a MASS, Michigan alcohol screening tool, and an audit. And those are the tools that I use to elicit more conversation about substance use. Primarily when a patient comes into treatment, they're asked an intake questionnaire, which I think that Zoe talked about in her facility. And so that intake screening questionnaire is a brief screening. Then that's reviewed again by another person. So when that would be your substance abuse counselor. And then eventually it may be reviewed by a medical professional. And when it's reviewed by a medical professional, the person is getting little snippets of what is not working for them anymore because they are being talked to it. They're using motivational interviewing with the person, and the person is learning to understand the harmful effects of drug and alcohol use on their body. So SBIRT is multifaceted. In Siena College, when it was in upstate New York, when the SBIRT model was first used, when I was first trained, it was used on the college students, and they found 75% reduction in the amount of alcohol and drug use on campus. And that was part of a college consortium initiative in upstate New York and Albany County. So the SBIRT model really does work, and it helps reduce the harm that many patients are facing.
So I'd like to shift just a little bit from talking about people who are affected to the people, more of a public health issue. A lot of you have mentioned shame as a barrier to getting any kind of help or intervention, or even just showing up at all. I think one of the biggest barriers is the attitudes that people have towards people who are struggling with substance use disorders. And given that we have a room full of different health professions, how do you have conversations with those people? You know, your friends, your family members, some of your colleagues, some of your supervisors, who have attitudes towards substance use disorders that are outdated, perhaps, that involve judgment and blame, because people aren't going to ask for help or even want to receive the great help that is out there or support that's out there. Shame is a big deterrent.
So the first thing that makes me think of is sort of the work that we did in some of our neighborhoods in Portland around, you know, as we started, it's like 2011, 2012, we started seeing and hearing in the news across the nation, we started hearing about this increase in opiate use specifically, and then we started seeing like the fallout of that in our neighborhoods, like needles being found in playgrounds and in parks, and you know, an overdose occurring outside of a school. And neighborhoods started getting really angry and frustrated and not feeling like, I think mostly just like kind of not knowing what to do. And so they started calling the needle exchange program every time they found a needle on the sidewalk. And at first it was sort of like, okay, sure, like we'll go pick it up. You know, we certainly don't want them on the streets. And we did that until I think I was about like 7 months pregnant, and then it just started to feel like we needed to come up with a more sustainable plan at that point. So what we did is we tried to really make sure that the community felt that our program was an asset to the community, that our clients were not vindictively throwing needles in people's yards because they wanted to. We also started seeing at that time really starkly the lack of resources that a lot of our folks have. At this point now, there are certainly treatment options in our community, but there are very few options if you don't have insurance. And even if you have insurance, there's all kinds of other things that come along with that. So there is not a single person that I haven't interacted with who hasn't at least wanted the opportunity to try something different. But very often that is where the conversation ends, because it's like, okay, there's two options and you have to jump through a million hoops to make it happen. And since then we've tried to adjust that. But really working in the communities was sort of the point, was our turning point, I think, because we were sort of being blamed for it, that's how it felt. We were being blamed for a lot of the drug use and the fallout from the drug use. And so we, as a city, we collaborated with Public Works, with the police department. We installed community sharps boxes, which at this point we have 11 of them around the city. We tried to make it very clear that we would do whatever we needed to do to help solve this problem for these neighborhoods that were feeling so defeated by substance use. And there continues to be problems, and we're continuing to collaborate. But I think regardless of who you're talking to, whether it's a family member who might not understand, trying to just have a conversation, hearing what people have to say, and then trying to help support whatever that may be, can really sometimes go a long way. And you can get into the moral side of it and brain disease and whatever your belief is. But again, I really think it goes a long way to just listen to what the person has to say and understand their frustration, because we're all frustrated by it ultimately.
We're right now, one of the things, working with all 16 counties and trying to help them, understand it and educate them. One of the big things is we're not going to educate everyone. People are still going to have their own perspective on those that are using substances, misusing substances. We can work together as a community. The communities are sick also. It's not just the person that is suffering from substance use disorder. It's the family, and now it's affected the communities also. We all need to heal. We all need that education. And one of the things that I see and as a frustration, and when I see that why so much the media loves to cover negativity, because that's what sells papers. Why? And then you have that, and then you always look through the comments section if you're online. That's a great place to look, because you have the keyboard warriors there that are sitting there that don't know jack. So why not, when I look at that and say, why not cover the good stuff? Why not talk to the people in the families that how they made it through, how they are doing in recovery, what helped them and stuff. People, we know we have a problem in Maine. We get that. I come from Washington County originally. We designed this in Washington County back in the 90s. So it's nothing new in 2017. We know we have a problem. We don't need the newspaper or someone coming in to have another forum to tell us that we have a problem. What we need to do is we need to start taking action steps as communities, as individuals, as people in recovery, taking action steps. We can talk things to death, but without those action steps, nothing is ever going to get better.
The only thing I was going to add was that so I came into my position a little over a year ago, and I sort of had the honor and privilege to spend time with people who are in long-term recovery and sort of hear their stories and hear the importance of changing the language that is used. And when I started my position, it was still called the Substance Abuse Prevention Program. And so one of the first things we did was we sort of took an inventory for all of public health around where we could change our language to be sort of more supportive and acknowledge, substance use disorder as a treatable medical condition, and talk about people who were, people who had people with a substance use disorder, people who are in long-term recovery, and sort of, I spend a lot of time doing some community education around overdose recognition and response. And one of the things that I feel like I can do is sort of set the stage for reducing the stigma attached to it by acknowledging it as a treatable medical condition, and acknowledging the words, the importance of the language that I use. And that's, I guess for me, that has felt like a small part, but it's something that I can do to sort of get away from the stigma that we attach to things.
And I think that's a question that can be answered on a lot of different levels, and I'm a guy that kind of likes to think about larger systems, and you know, kind of advocating on for legislation for more treatment access, and like on a personal level too. I think it's critical with people with long-term recovery kind of put that out there, you know, and because I think a lot of people who like first responders and primary cares, we see like all the nitty-gritty and the bad stuff, and a lot of people, when they think of long-term recovery or recovery, don't really see that there's people with multiple years of recovery who are kind of doing positive things and being helpful. And I think that was kind of the conundrum I was under, was like, do I disclose that I'm in recovery because I might face some stigma? On the other side of that is like, if I do, it's like, yeah, I'm a person, and I'm here, I'm in school, and so I think it's changed on a lot of different levels. I think language is important, but also too, like advocating on the legislative level and the government levels. You know, I mean, I've heard things that there's policies to further cut like Medicaid, you know, and so I think like advocacy on those larger systems level is really, really important, because that's going to provide access to treatment and reduce stigma. So that's kind of my 2 cents on the question.
When I think back over the years of counseling, and I met with clients to develop their treatment plan goals, and I'd ask them what is their goal, the majority of them would say, I want to be clean, I want to be normal, and I don't want to use again. So that's all relative. We have to help them decide what normal is, what clean is, and what not using again is as clinicians. But just changing our language and helping them change their language is key. You know, for years in the addiction field, we would say you're dirty if you have a positive urinalysis. Take the dirty out, it's shame-based. Start using language that's more appropriate. Your urinalysis was positive for cocaine. Talking to them in realistic ways so they're building themselves up. This community does an excellent job to support Recovery Month, but support those individuals all year long. Support them, celebrate them, welcome them into programs, give them welcome packages, help them feel like they're not dirty.
And I'll just quickly add just one more thing, is that I've actually had to, you know, where I work right now, I'm the only clinical social worker. So there's a lot of staff in recovery, there's professional counselors, but you know, my training is a little different, so I've had to, and where I work is an abstinence-based recovery model. It's very 12-step, so there's a lot of attitudes which aren't really in line with my own values and in my training. So I've had to kind of model, like, how do you work with people, you know, like how do you treat people with respect and dignity, and really kind of put myself out there. So that's been another challenge for me in my recent career. So even within the own treatment industry, there's a lot of old attitudes and ideas that aren't really helpful. You know, it's kind of like this tough love stuff, and these people don't know how to make decisions, and so I've had to kind of model like a different approach even with my own job. So.
Thank you. We're down to the last couple questions, so be thinking about what you want to ask.
So my name is Neva. I'm in the pharmacy program. And they offered a ride-along with Milestone through UNE. And so I was like, that sounds cool, let's do it. And it really opened my eyes. I'd never even experienced homeless or a soup kitchen or shelter. But one of the biggest things that resonated after doing that was that there's no follow-up. So we bring them back to Milestone, they sleep it off, they get a shower, they get food, they get their clothes washed, whatever, but at 7 a.m. they kick them back out onto the street. So, and I'm sure Oliver, this is kind of directed to you, but how hard is the follow-up and to see that on a daily basis? Because I did that one night And I was like, what are we doing? You know, we are offering them housing and food for the night, but really, is that helping them or is it hurting them? Kind of thing. And also, I just want to commend you guys that are in recovery, that are helping others, because I'm sure that sinks in a little more than someone who's not using and never experienced that. So just want to commend you guys on that for sure.
So it's not easy to see the same thing over and over again. But you know, I think Zoe was talking about it earlier. We're really sort of planting seeds or keeping the door open, building relationships. For some people, the only person that cares about them is someone from home team, you know, or at least that's the way they feel. So we need to foster relationships with people that maybe don't have anyone else, because when they do want to do something different, whether that's get into recovery or just do something different for that day, be in a safe space for that day, we need to be available to them. So that's really sort of how home team works. That's sort of how my program works as well. We just, and really most of the people up here, I would think, you're building relationships with people, kind of going where they want to go, going on the journey with them, being there with them, because they feel isolated and alone, and you just being there with them is so powerful. You know, a lot of times people, I think it was said earlier too, people were ready today, but there's nothing for 3 weeks. So how do we keep you safe for 3 weeks? You know, sometimes that's not possible. So most people that we work with down in Portland, especially in the shelter system, don't have any insurance. Most of them don't have, you know, family available to help support them. So they're really kind of relying on us outreaching them, or safe spaces like the Needle Exchange to go engage with staff. It does sometimes feel like sort of a revolving door, but there are people moving through that system because of that revolving door. They're always open, always available. But yeah, I mean, outreaching is, I'm kind of lucky in a way that there's a shelter because I know where people are most of the time. So it's easy to find people and interact with them. And if there's not emergency calls going in, that's what I'm doing, kind of similar to home team where they're outreaching people. I'll go find people and just talk with them, see what they need. I think something that I was going to say to the other question, and I didn't, but I think sometimes we focus so much on the substance use, we lose the rest of the person. And I try to focus on kind of the holistic approach and like finding something else apart from the substance use that we can build on. How that looks like in the hospital, sometimes people don't even get checked out medically when they come in from an overdose. They're just looking at the overdose. They might have trench foot, they might have an abscess. You know, they might do a quick look, but they're not really necessarily doing a full evaluation unless that person says, oh yeah, I got a huge abscess on my arm. So I just think like sometimes we so focus as providers on this one thing, we lose the rest of the person, and that person's already lost a lot of themselves through their use. And so helping them find that and building that up as well, sometimes that's, maybe they can't stop using, but they can do something else to move themselves towards their recovery. So I think we want to remember that as providers. Do you have something?
The home team was a big driving force behind putting together that community paramedicine project, because for about 3 hours of the 10 that they spend in the shelter every week, they are riding with the home team, and you know, the folks who kind of oversee the home team were really just felt really strongly about having somebody with a medical background, getting their eyes on people and being able to address other needs, especially folks who were kind of like, you know, not spending time in the shelter and who are out on kind of the outskirts and kind of marginalized, and, you know, just making sure that people had access to food and water and some of the other things. And if you know, like Oliver said, if there was trench foot or other things that could be addressed, none of that would ever hurt a person, right? So any sort of compassionate care that can be provided is not lost.
And I think too, there's also there's like certain models, like housing first models, low barrier models. I believe there's like Logan Place and a couple other places where there's people don't necessarily have to stop using drugs and alcohol to have housing. And I think that kind of those kind of models and movements are really important, you know. And I think perhaps what you've seen is that we kind of have this attitude of people are homeless, like that's a choice, you know, and kind of shame them. And so I think kind of more of like a prevention and harm reduction kind of strategy is really effective, and I think that's what we're seeing in the Portland community. So I think it's moving in the right direction, but you're right. I mean, for someone who goes into the hospital with an overdose, is homeless, does not have a family ties, it's really in a tough position, because like, what are they going to do after? There's not a whole lot of like follow-up and support. So, but like I said, I think that is changing, but kind of from a social work perspective, kind of like offering, taking care of people who are not as fortunate and having these safeguards in place. Thank you for your question, though. That was awesome.
So I've heard advocacy for your patients and also in the greater community in a public health way. I've heard listening, being empathetic, motivationally interviewing. We have just 10 minutes left, and I thought it might be a good idea to give everybody a chance to a closing comment of some kind. If you want to sum up, or if there's something you didn't get a chance to say that you'd like to say. And if you're at a loss, I think our health profession students would love to know, like, what's the most important thing they should be doing when and if they have the opportunity to intersect with these folks.
Okay. I'll take it first. See, and I went last at the first of it, so. I guess, you know, where I would say I receive a lot of calls during the day. And there are calls from people looking for assistance to family members. It happens until 7 or 8 o'clock at night when I'm home. I may have a mom that's crying. And a lot of people don't know where to turn. People think immediately that this is one thing that's ingrained in their minds is rehab. Okay, we need a rehab. Well, you know, I'm not even going to go there. I'm not going to get on the political side of it. Many people aren't insured. They don't have that. What we provide, what my organization provides, and what I train people for is to be peer recovery supports. And what I've run into some great people that continue to do that. However, we've become a society, unless we're getting paid for something, we don't do it. What the hell happened? I look and I think, what happened to us that you can't even, a person can't even go and take their elderly neighbor when it's wintertime and shovel off their doorstep without getting paid for it. We are human beings. We care for each other. I think we really need to, it would be nice to come back to that because that's the way things were where I grew up. And, you know, if we can spend 10 hours on the internet in one day, I think we can spend an hour with someone that may need our help, just to be there. You know, because Ernie Larson said it best, and I know that Lila's heard this from my trainings, but everybody needs a good listening to. If we could just take an hour of our time and listen to someone, that may help them through that day and be a peer support for them.
So quickly, I'll just say I want to thank you guys for being here, and I think that's huge. You know, I think like people who are willing to kind of put themselves out there, and like this is like a College of Westbrook Medicine. You know, this is like the future of health professionals, and I think just your presence here and your willingness to kind of listen and learn it says a lot. And I guess the thing for me, I'll close with this, is just the belief in people, you know, and how everybody like innately has their own like tendency for positive growth. And in my experience of, I met with Shelley, who left earlier, but you know, when I decided to come here, I could tell that she really believed in me. And I feel like a lot of people who are in recovery have that stigma and that shame, and they don't feel like anyone believes in them. So even that kind of like compassion and a belief in someone's ability to recover and live a good life is so important. And I'm really grateful you guys are here, and I really appreciate that you are here to kind of be a part of this.
I just want to say that piggyback on what the other people have spoken is to just be welcoming. People that have an addiction feel a stigma deep down inside. It's a dark place for them. They're very shame-based. They're shameful about it. As welcoming as you can be, as open as you can be, giving that listening ear, giving support, providing resources. And I'm a person in long-term recovery, and I didn't get to be what I am if I wasn't in long-term recovery, because I had people that listened to me a long time ago, people that gave me support, people that shared their personal testimonies of recovery with me. Recovery is a lifelong process. It's also a family problem, and it's a community problem. Maine is in the top 10 of the states ranked by the CDC for excessive opiate overdose, and we all know that. And if we're more caring towards our neighbors, towards our friends, and we try and destigmatize what they're going through and help them through the program, that whatever step they're going to take to make a change and celebrate their recovery, that's the best we can do. So thank you again for taking this time to listen and to be a support in your community.
So much to say, but I think I'm going to keep it short and say, to me, the best thing you could do moving forward is just be kind, really to everyone you meet, but especially people that you know are struggling with substance use disorder, and hold hope, even if they don't necessarily have hope for themselves. Hold it for them until they get that hope back, and you can show that through your kindness. So thanks for being here.
Yes, thank you guys so much for spending your time with us this afternoon. And I guess I would also just sort of echo what Oliver and what everybody else has said. And I guess I would encourage you not to sort of like lose sight of your own gratitude around, you know, being able to do what you're doing. And I feel really honored to be in the presence of people who are willing to share their stories with me, and people who are in long-term recovery who are brave and able to kind of share that with the world. And I feel like I am a few fortunate life circumstances away from a very different life, and I try to always keep that in mind. So again, thank you so much.
I guess the one thing I wanted to say is just that, you know, we talked about harm reduction a lot as a philosophy in reference to substance use, but it's important to know that harm reduction as a philosophy is something you can apply to many other things. It's oftentimes spoke with substance use because it really, that was sort of the foundation of it. But working with any patients or clients who have anything that they are identifying that they want to learn more about or change in some way, you can really reduce the harm or talk to them about ways to reduce that harm, whatever it may be. So keeping that in mind. And then also just, you know, the idea that like we are essentially, we've come a long way, but we are still just offering a lot of Band-Aids, you know. I mean, Milestone, that example always makes me think of that. So being a voice for your community, you know, like we need more than just Band-Aids, and we're all gonna keep just being those Band-Aids, but like we need bigger Band-Aids too. So, you know, advocating for your patients, if you see that something isn't right or somebody's treated in a way they shouldn't, like you know, you have that authority to make that change and to sort of create a change that can sort of be infectious in a good way. So, thank you.
I guess I'm ending this. It better be good. You know, as this next generation of healthcare professionals, I really would ask and urge you to be allies to people affected by substance use disorder. That includes the language you use. Please, as healthcare professionals, use the language that promotes recovery and lowers stigma. You know, everyone here has said this is a community thing. So again, standing up for people and just, gosh, now I feel like I'm not going to end it very well, but being that ally. And should I drop the mic? I don't know. There I go. Be an ally.
Excellent. Thank you. Thank you very much to our panel. Thanks for spending your time with us today. And for the rest of you, have a great day. If you're interested in SBIRT, let us know. We're at sbirt@une.edu. Send us a message.